In 2001, I was working at a rural hospital in Vermont. We had 2 operating rooms there, and I was half of the total number of anesthesiologists on the medical staff of the hospital. One morning, I was conducting a pre-op anesthesia interview with a female patient. The patient's husband was at her side. He repeatedly interrupted my conversation with his wife to say something about his own recent episode of surgery. His surgery had taken place 45 minutes drive away at Dartmouth Hitchcock Medical Center in New Hampshire. I fought off his interruptions until I had completed my discussion with his wife. At that point, I said to him, "So what exactly happened to you at Dartmouth?" It seemed his coronary artery bypass surgery did not go well at all. He experienced post-operative bleeding that brought him promptly back to the operating room. Back again to the ICU, he then needed transfusions and then required a full-blown resuscitation effort. A lung collapse necessitating a second round of chest tubes. And finally, he had a sternal wound infection that required yet another trip back to the operating room. He stayed in the intensive care unit at Dartmouth for almost a month. I expected a story like that to end with him saying something like, "And Doc, I am never going to step foot in that hospital again, ever." But instead, he finished this grueling story by saying that he ranks the Dartmouth Hitchcock Medical Center the best hospital in the world. How could he possibly give such an exalted evaluation to a surgical team that almost did him in a couple of times? Is that insanity or something else? I think this patient's opinion of Dartmouth Hitchcock Hospital comes from a very different place. And it's that place and how to get there that I want to explore with you today. I intend this video presentation primarily for students of anesthesia, either physicians or advanced practice nurses. I will focus on the pre-op patient interview, although you will recognize quickly that some of the concepts covered here have much wider application. And I'm going to talk mostly about what the patient needs from your encounter, because I know that what the anesthetist, whether nurse or physician, needs from the interview, you are aware of already from your studies and clinical training. But first, what originally lured you into the field of anesthesia? Most of us were attracted by the immediacy and the drama of anesthesia. We like the challenge of putting together complex pharmacology and physiology in a procedure-based specialty. And obviously, we all recognize that anesthesia is magic. General anesthesia just happens to top the list of America's greatest contributions to medicine. The real question then is, why doesn't everybody want to make life and death decisions every day of their career as an anesthetist working in the inner sanctums of medicine? Perhaps high stress does not work for everyone. If you do not yet fully appreciate the stress that comes from anesthetic practice, give it time. Also, in perhaps more time, I believe you will find that the intellectual challenge of physiology and pharmacology you've worked diligently to master will become second nature to you and less of a challenge, although there will certainly be new things to learn throughout your career. I'm trying to make the point that Many of the exciting things that brought you into the practice of anesthesiology will grow routine. And as that occurs, the stress of the job has been known to cause burnout. On the other hand, aspects of your practice that currently may not pique your interest will, over the length of your career, take center stage. As your hair grows grayer like mine, I expect you will come to enjoy the specialty of anesthesiology primarily for the great joy you experience helping your patients navigate the emotional stresses of their treatments and procedures. That part of your work has little to do with physiology or pharmacology. It has everything to do with who you are and what you say and do. This part of your work comes into play every time you stand before a patient to begin your pre-anesthetic interview. In that moment, you constitute the therapy. Your empathy, your personality constitutes the therapy. If patients start to request you specifically to provide their anesthetic care, they will do so not because of your medical knowledge, that's a given, but because of the feelings you project. Commonly, we call that projection your bedside manner. That's really our topic here. I want to dig deeply into that quality. We are looking for that thing that induced that man back in Vermont to heap his highest praise on a hospital that seemed to have come very close to killing him. Whatever that quality looks like, that power that caused him to praise his doctors and nurses so highly despite those serious complications, that quality is something very important for a career in medicine and definitely very important for a career in anesthesia. After working in Vermont, I moved to a practice in Connecticut. At the Connecticut hospital, an administrator asked me to lead a team of perioperative staff members seeking to restructure the work processes in the OR to make patients, and especially the staff, happier. The team, it turned out, was very unhappy with many aspects of their jobs, and they therefore were enthusiastic over the opportunity to make things better. But the team struggled for hours and hours trying to define precisely the measure of their real objective. Actually, the team members were quite clear and very specific about their own expectations and desires for their workplace. But those same individuals, many of whom had worked for years in healthcare, struggled to capture what their patients actually wanted from them. The best they could do seemed to boil down to words like competence, proper care. I remember pointing out to them that proper care and competence seemed more like minimum expectations. The team was actually being asked to define a quality of care that patients would judge as extraordinary. Try as they might, they could not nail it down. They could not define extraordinary patient care. At the next team meeting, I brought in some books from the business section of the local bookstore. These books were intended for business leaders, and they dealt with excellence in customer service. One of the books noted that customers return over and over to businesses where they believe that the business cares more about them personally, as individuals, than they care about making a sale. One of the members of our team finally took that concept and translated it into, our patients want to believe that we care more about them as individuals than we do about their disease. The team immediately made that translation into their mission statement, their guidance for making all the other decisions they needed to make in the design of a new workflow for the surgical process at their hospital. But what does it mean to care about the patient personally? I was fortunate early in my life to know John Caldwell Fletcher. I doubt that you've ever heard of John Fletcher. John Fletcher's sister, on the other hand, Louise, became very well known as a movie actress, winning the 1976 Oscar for her portrayal of Nurse Ratched in the film One Flew Over the Cuckoo's Nest. Her brother, John, was not quite so famous. He had pursued a career in parish ministry in the Episcopal Church. From parish ministry, he went on to become more widely known as Dr. John Fletcher, educator and chief bioethicist at the National Institutes of Health. Dr. Fletcher wrote books and manuscripts on medical ethics, and in those writings talked about the way providers should interact with their patients. In a chapter in a book entitled Coping with Genetic Disorders, Fletcher introduced the concept he called authenticity. Authenticity. He said that was the prerequisite for being able to provide meaningful guidance to people, both religious guidance and medical guidance. Fletcher used the word authenticity to mean the recipient of the guidance, our patient, will not accept advice until he or she has granted authenticity to the individual offering that advice. That would be us. If you were to search for books on authenticity, you would find that most authors have used this word, authenticity, to mean being true to oneself. Fletcher differentiated his use of the word authenticity by saying that he meant the word to substitute for the phrase faithful companion. So the idea of authenticity meaning true and valid stays the same, but Fletcher is talking more specifically about how one becomes true to someone else instead of just true to oneself. Fletcher argued that gaining acceptance as a faithful companion to someone else, or gaining the rank of authentic, unfortunately takes time and it takes effort. Not exactly what we want to hear. I personally was hoping for a trick, better yet, a quick, foolproof trick. Clearly, anesthesia providers rarely have a lot of time to spend getting to know each patient. We meet a patient and we literally ask them within just a very few minutes to place the safety of their very lives into our hands. When you think about that, you wonder if it's ever reasonable that a patient could trust us with their lives after just a few minutes conversation. No wonder we usually resort to potent sedatives to persuade patients to go with us peacefully into the operating room. Having said that, I still believe that if we focus on what Fletcher was saying, we may still find something useful, even when we only have less than 10 minutes. Something useful that can boost our authenticity, our image as faithful companions. The faithful companions in each of our lives are people who are genuinely interested in us and in our feelings. Faithful companions exhibit compassion, invite our trust, and display honesty and humanity in what they say and do. Our patients want us as their faithful companions. So, thank goodness, when we make an effort to be that, they generally give us the benefit of the doubt. That assistance to our authenticity that our patients heap upon us represents, I believe, a treasured gift that will become for you a key sustaining element of your rewarding career in medicine. A book Fletcher edited entitled Introduction to Clinical Ethics has a few pages of specific tips that may help us in our quest for authenticity. He actually presents these tips under the heading of Training Clinicians to Deliver Bad News, but they're very much about the role of faithful companion. I will attempt to summarize. Numerous studies demonstrate that patients evaluate clinicians more by their communication skills than their clinical skills. We show compassion when we seek a private setting for communication. We invite trust when we focus our full attention on the patient and no one else. No matter how many people are present, the clinician should speak first and most directly with the patient. Don't forget to establish accurately to whom you're speaking and what name that individual wants you to use. A faithful companion will not assume that everybody wants to be called by their first name. These details prove highly important, especially when we only have a few minutes to get it right. Anesthesia providers routinely meet patients who are lying in a bed or on a stretcher while we're standing over them. We are therefore literally talking down to the patient. The listener can't help but feel that they're being talked down to. It's literally true. So, if at all possible, sit down or bend down so you can get your face level with theirs. If you absolutely cannot get to the same level as your patient, you need to call attention to the problem and apologize that you cannot get where you want to be. Your apology can level the playing field, so to speak. If you talk to a patient while standing in the doorway of their room, you're essentially wasting their time and your time. Your body language will be screaming louder than any of your words. Obviously, you need to introduce yourself when you meet a new patient and explain your role. I'm sure you do that routinely. Be sure you do that looking directly into the patient's eyes. What about physical contact? Yes, a handshake or a touch on the patient's shoulder signals your humanity, provided you sense that gesture is welcomed by the patient. Some physicians have adopted a no handshake policy to reduce the spread of infections. If you've done that, you need to explain that decision briefly to the patient because that explanation shows your consideration and respect for them. Fletcher emphasizes that active listening by the clinician constitutes a much more important communication skill for the clinician than speaking. To listen well, one must have a comfort and patience with silence. And for most of us, that quality proves incredibly difficult in the midst of the pressure to not waste any OR time. But often that tolerance of a moment of silence communicates volumes. Sales trainers in the business world have long recognized that people most quickly like and trust individuals who are similar to themselves. Stores often teach sales personnel to consciously try to match the client's tempo and tone of speech. And using that tone and tempo, reveal their own attitudes and experiences that they have in common with their client. By tone of speech, I mean that if a patient is sad, the clinician needs to take on that sadness in the tone of their speech. It can prove helpful for the clinician to clarify the patient's mood and its cause if the clinician cannot sort out the patient's feelings. Getting the mood right can prove complicated if the patient has conflicted feelings. Sorting out the mood and emotion is something a faithful companion must do. You can and you will develop your own style around these principles. But to evoke trust, you must learn things about your patient other than just their medical history. And you must reveal things about yourself before you can expect the patient to authenticate you. In this process, each patient interaction will prove unique, and that's the fun part. It's interesting that the anesthesia literature years ago documented that in this process of authentication, the patient can actually alleviate more of their anxiety than they do from receiving our anxiolytic medications. I have a method I use to initiate my patient interviews. My method is just my way, and clearly not the only way. You will evolve your own style. I start by introducing myself, and then I lean close to the patient and I say quietly and sincerely, "I'm sorry you have to be here today." And then I wait and listen. Most patients will pause a moment because my comment, said earnestly, catches them off guard. Sometimes they say something like, "Well, actually, I'm really happy to be here. I'm finally getting this problem solved." Others tell me other things, their fears, their anxieties, or the extent of the disruption their medical situation has brought to their lives. It's then my job to connect myself to what they have said. Often I need to clarify what they meant, so I ask them. Once I understand their message, I share my own feelings or experiences that match theirs. If I can't do that, I tell them as accurately as possible what I understood about how they're feeling, so they appreciate that I'm struggling to share their experience. A faithful companion has empathy. But never, and this is very, very important, I never try to talk the patient out of any feeling they express. It won't work. And if I try to do that, I will immediately destroy any authenticity. Let me give you a common example. Patients often say they are frightened to death of surgery. And I often hear medical professionals trying to provide an array of reasons that there is no need for fear. I know they mean well, but let's face the truth, surgery is frightening. So in this situation, I respond to the frightened patient by saying, "Of course you're frightened. I promise you I would be much more frightened than you appear to be under these circumstances. Being frightened means you are intelligent, you understand what's going on, and frankly, you're normal. If I can answer any questions about what to expect, I want to do that, but I cannot begin to change how you feel. I'm going to stick with you the whole time. I will be focusing my total attention on your safety and comfort every minute. I don't know how to make this easy, but I think together we can do this." As time allows, I ask my patients about their careers, their families, their lives. If they want to joke with me, I try to joke with them. If they want to cry, I commonly end up getting choked up also, despite my best efforts. I think that's what we're there to do. And being faithful companions means we share our own experiences, our own concerns, our own weaknesses, and humanity. The process of study that we go through to become healthcare professionals gives us a huge number of things that we must think about as we do our jobs. Those important things we have to think about also serve to distract us from the aspects of our jobs that easily become overwhelming if we dwell on them. Our patients, however, are focusing on those very overwhelming life and death concerns, and we have to recognize that our desire to explain them away may not be entirely for the benefit of the patient. So I believe to become authentic in the eyes of the patient, we indeed do have to become authentic to ourselves. Better yet, let me quote John Fletcher directly. "The problem," he writes, "is due to the condition of being human. It is never the lot of humans to be secure." I think Fletcher is telling us that as clinicians, we share insecurity with our patients, and furthermore, we're at our best when we share, genuinely, the weight of that insecurity with our patients. That sharing, the bond of empathy, constitutes the greatest gift we give to our patients, and ultimately that bond becomes the greatest gift our profession gives back to us. I do understand that the pre-op anesthesia interview must also include reviewing the patient's medical history and an examination of their current physical status. But I generally find anesthetists in training know pretty well how to do that. I don't want to spend time here on that topic. I'm also pleased that computer technology, as it matures in healthcare settings, reduces the time and the effort we need to spend redundantly rehashing medical histories with the patient. These advances give us more time to spend on our important role as faithful companions. I've talked so far about authenticity as a quality earned from each patient and bestowed on a specific clinician. I would also encourage you to recognize that the same virtue of authenticity can be applied to an entire institution. The steps that an institution takes to promote authenticity, when effective, can make it easier for patients to perceive their clinicians as being authentic. Institutions project authenticity by carefully designing their patient care experience to allow patients to feel that they are consistently receiving personal, individualized, and professional attention. Signs of diligent and respect for the individual, cleanliness, and attention to detail in many dimensions convey authenticity. Some institutions have copied the Walt Disney philosophy of designating all staff behaviors and activities as either being on stage or backstage. The public is never allowed to see anything designated backstage. Conversations between staff members, both professional and personal, are always backstage. Transporting the laundry, backstage. Anger and frustration, definitely backstage. Fixing the plumbing, backstage. Even running with equipment to save a life in an emergency, backstage. In a similar fashion, authentic institutions foster internal authentication of its staff at all levels. By internal authentication, I mean that the healthcare providers actually actively authenticate their colleagues. Staff members at all levels are taught to draw the attention of patients to the experience and capabilities of other team members. Patients love to hear from the admitting clerk that their surgeon has the best outcomes. They also love to hear from the doctor that their amazingly attentive nurse absolutely will not let the doctor leave the hospital until everything is right with the patient. You might think that a clerk's evaluation of a physician has little importance to the patient, but studies show exactly the opposite. The evaluation of one physician by another appears to carry less weight, perhaps because the patient sees that endorsement as a professional courtesy. When an anesthesia provider endorses the ability of a patient surgeon in a sincere manner, both providers appear to gain authenticity, and so does the institution. And may I add one additional observation? We all respond to suggestions. If you ask about sadness, I think about sadness. If I ask you not to think about green ice cream, you cannot help but picture green ice cream in your mind's eye. If I ask you to rate your pain, you have to focus on pain. On the other hand, if I ask you if you're comfortable, it's the same question, but you focus on comfort. Talking about comfort fosters comfort, while talking about pain fosters pain. If I ask you if you have any discomfort, you're still focused on comfort. The root of the word forms the suggested impression. I would encourage all anesthesia providers to use the words that suggest the outcome you want. Don't ask about pain or nausea and other unwanted symptoms. Ask about comfort. Ask, how calm is your stomach? Or do you feel strong? Do you feel in control? Suggestions, as you know, are very powerful, and your words have a great deal to do with the perception of subjective symptoms. Beth Israel Deaconess Medical Center in Boston has launched a campaign to enhance the authenticity of their hospital by promoting what they call their Human First initiative. They say, we never forget that before you are a patient, you're a person. While Beth Israel is clearly a very fine hospital, I would argue that they have selected the wrong wording. I don't think patients want to be thought of as just human. They want to be seen as unique and valued, like a close family member. I actually find the Beth Israel Human First advertisements off-putting, although I believe they mean well. Perhaps they aimed too low. I live in Vermont. In Vermont, we have a short growing season, and farmers hurry each year to get their crops planted as early as possible, which means there is generally lots of mud around when their planting starts. There's an often told story of a Vermont farmer who got his tractor stuck in the spring mud right up to the axles by trying to start his planting just a little too early. He went to his neighbor for help. The neighbor farmer listened to his plight and responded in a typical Vermont manner. He said, "I'll get my chain and tractor and see what I can do. But you're in pretty deep, so it might not come out today. In that case, I'll just sit with you in the mud. Very often, a faithful companion just sits in the mud with you when all else fails. And that means everything. I hope my comments here have encouraged you to pay a little more attention to yourself. Not what you can do, but who you are, as an important instrument of healing for your patients. In many instances, who gives the medicine proves just as important as the medicine itself. You and who you are creates powerful therapy.